Good morning, Professor. Can you hear me?
I can. Good morning to you, Sir Brian.
Good morning, Ms. Richards.
Professor Ludlam, I'm going to be asking you this morning questions relating predominantly to 1983, 1984, and issues relating to AIDS. I'm not proposing...
Could I, just before we start, bring to your attention our discussion yesterday, about hepatitis outbreak in Edinburgh. You asked me about how I first heard about hepatitis, and I indicated that I had been a student at the time of the hepatitis outbreak, and that I had worked with one of the staff who died. And I indicated that I thought that 4 members of staff had died and 4 patients had died. You, I think, at that time considered there were 11 patients and 1 member of staff. I went away and did a little homework last night because it was a major event in my life that I do remember, and consulted a very good paper that Barry Marmion wrote, who was professor of virology in Edinburgh in the 1980s. And it appears that from his report, which I can forward to you, there were 4 members of staff who did die. 1 was a surgeon, 1 was a junior doctor, 1 was a receptionist in the haematology department at the Western, and 1 was the research technician I mentioned as well. And there were apparently 8 deaths of patients. I hope the inquiry will find that helpful.
Thank you, Professor.
I'll send in the Barry Marmion's paper.
Thank you. I also checked after yesterday the Rosenheim report, which is where my figure of 11 had come from, and I had... you're right that there were more staff than that. The Rosenheim report gives the figures of 8 patients and 3 staff, but it may be that the further death that you relate was not included in that. But thank you for that, and we'll ensure that we check both materials.
I think that it will be 3 because it was 3 hospital staff, and the blood transfusion staff, a member of staff, was not considered hospital staff. I think that makes up the numbers.
Thank you. Well, that would make sense of the numbers.
Yeah.
So, Professor, I'm going to concentrate on issues relating to HIV and AIDS this morning. I'm not proposing to ask you questions this morning about the AIDS study, the research, monitoring, surveillance, however one is going to term it, work that you were undertaking. I will be asking you about that probably tomorrow when we look at some other issues relating to research. I hope that assists in understanding the direction of travel this morning.
Thank you, that's helpful.
When and how, as far as you can recall, did you first become aware of cases of AIDS in haemophiliacs?
I can't remember exactly when, but it, as you know, the MMWR report was in July 1982 of the 3 cases. That was not on a journal, it was on my reading list. It's a rather specialist journal for those interested in public health and infectious diseases. And it also takes a little while to travel in those days across the Atlantic from CDC. I would think probably September or October. I'm sorry, I can't be more precise. Maybe August, but that sort of time.
Now, we know, and we'll come on to this later, that in September of 1982, there were some brief discussions amongst the reference centre directors in relation to AIDS reports, and Dr. Krask was tasked with providing a report or going away and researching the matters and reporting back. I'm going to ask you to look at one report from Dr. Krask that did come your way in November of 1982. If we could have, please, Shumik, HCDO 273_079, please. So we can see, Professor, that this is a letter dated the 11th of November 1982 from Dr. Krask addressed to you. It's entitled AIDS and Haemophiliacs, and he says, I enclose a copy of a paper I've prepared for the meeting of the MRC Hepatitis Vaccine Working Group, which describes the most recent information available about this new syndrome. In the second paragraph, he talks about his telephone conversation with CDC in Atlanta and the latest information he'd received, which was that 5 haemophiliacs had been identified with the syndrome, 2 of whom had died. All these cases are without the usual association of homosexual practices, drug addiction, or treatment with immunosuppressive drugs, factors which have been found in other patients. And then in the third paragraph, he says the hypothesis at present being used to explain the acquisition of these cases, which are in areas of the USA where the syndrome had not been hitherto described, is that 1 or 2 patients in the incubation period of the disease donated plasma, which has since been used to prepare factor 8 or 9 concentrates. All the haemophiliacs who've had the disease have had severe coagulation defects requiring regular treatment with factor 8. The likelihood is, therefore, that other cases will be identified amongst severe haemophiliacs, though probably at a low prevalence. And then he goes on in the next paragraph to say that there should be a meeting of the working party. Presumably, Professor, that would be the hepatitis working party.
I presume so, yes.
And some dates suggest it.
Yes.
Now, we'll have a look at a copy of the report that he is sending you. It's a different reference, so Shomik, it's HCDO 40557. We can see this is, in fact, a letter to Miss Spooner at Oxford. It's the same date. The text of the letter is the same as the letter to you. And if we go to the next page, please, Shomik, we'll see a copy of the report itself. It is, I'll check the date. Dr. Krask has dated it November the 5th, 1982. And if we just jointly have a look at it, Professor, we can see that in the first paragraph, he provides an outline of information received from the CDC in the States. If we look at the second paragraph, he talks about the infections. And then in the third paragraph, he talks about a delay between the occurrence of initial symptoms and diagnosis. He sets out signs and symptoms, excuse me, being in most cases insidious and non-specific. And then if we go over the page to the top of the next page, he talks about the high mortality rate, age range 15 to 57, and then there is a discussion of laboratory data. And then if we look to the bottom of this page, under the heading etiology, he says this: several theories have been advanced. It seems likely that this is a new syndrome, and then we'll see he sets out 3 theories. One is effect of drugs such as amyl nitrate, and he says this is not a factor, as the disease has been described in patients who do not use the drug. Would you agree with me, Professor, that Dr. Krask is identifying that as a theory that's been advanced, but discounting it in this paper?
He is discounting it for the patients with haemophilia who have developed AIDS.
Yes. Then he goes on, his second theory, the immunosuppressive effect of cytomegalovirus infection, and he goes on to say this seems unlikely, as CMV infections rarely the primary cause of profound immunosuppression. Go to the top of the next page, please, Shomik. In patients with CMV-associated infectious mononucleosis, etc. And then his third theory that he's setting out, the association with sexual promiscuity, intravenous drug abuse, and possibly the transfusion of commercial blood concentrates, together with evidence of clustering and a prodromal phase, suggest an infectious agent with similar epidemiology to that of hepatitis B, possibly specific for human T-cell populations. And then he goes on to say, if 3 is the most likely cause, then it seems possible that such an agent might be present in the plasma of hepatitis B carriers used to prepare hepatitis B vaccines, and then goes on to set out a number of matters that would no doubt have been relevant for the purposes for which this report was prepared, which was the MRC's hepatitis vaccine working group. Would you agree that looking at this paper, the theory that Dr. Krask is advancing as the most likely is the third theory, an infectious agent with a similar epidemiology to that of hepatitis B?
I think this letter demonstrates the uncertainty that there was at the time about the cause of AIDS. We haven't had a discussion about the definition of AIDS. We'll perhaps come back to that later. But the question of, excuse me, the question of the etiology of immune suppression and AIDS in haemophilia, the etiology of it might be a virus, it might be something else. It's, as you know, there is this theory that blood products themselves altered the immune status of recipients. And there was a suggestion and some evidence that I'll perhaps come on to later to demonstrate that the immune status, in fact, of HIV negative haemophiliacs was in fact suppressed. And in this time, the late 70s, early 80s, there'd been a big increase in the amount of clotting factor used to treat haemophilia. And there was the suggestion that there could possibly be if I can put it this way, parallel etiologies for the AIDS that was appearing, that in homosexual men and that in people with haemophilia might have different etiology. I'm not saying that I didn't think it possible or even likely that there might well be a virus that could spread in the clotting factor concentrates. Clearly, as soon as the first 3 cases were described in July 82, and the possibility, it was well established that amongst homosexual men, it might be a virus that's causing the syndrome that was well described in them at that time. So there was clearly the possibility of a virus, and the virus could have got into the concentrates as described here. But there was a lot of uncertainty at this time about and puzzlement, and the puzzlement in some people's minds about the viral etiology of AIDS extended until at least 1992, when I had to reply to an article in The Lancet suggesting that AIDS was not due to a virus. So I think at this time there was much uncertainty, but a viral etiology was perhaps the most likely.
Now, you became aware, I think, of the reports that were in the MMWR in December 1982 of 3 cases, transfusion-related cases, including the case of a 20-month-old infant in California. You became aware of that in either late 1982 or early 1983?
Yes, that would be early 1983.
And we'll look at a handful of documents that relate to that. But before we do so, can we just look at the New England Journal of Medicine for the 13th of January 1983, PRSE 302410, please, Shomik. I think you've already explained to us that the New England Journal of Medicine wasn't on your regular reading list. We'll see how this would have been drawn to your attention at meetings in January 1983 in a moment. But in relation to this particular article in the New England Journal of Medicine, AIDS and Preventative Treatment in Haemophilia, if we go to the second page, please, Shomik. And if we look at the last paragraph from the left-hand column, we can see there, this is the article by Jane Deforge, the opening sentence, the fact that haemophiliacs are at risk for AIDS is becoming clear. And then she goes on to talk about the need for physicians involved in the care of haemophiliacs to be alert to the risk, talks about the possibility of revising home treatment programmes, and in the last sentence says preventing the complications of the present treatment may have to take precedence over preventing the complications of haemophilia itself. Now, do you know whether you read this article at the time?
I was certainly aware of it early in 1983. It would be obviously after the 13th of January, but I was aware of it, yes.
We'll come on to the question of whether greater use could or should have been made of cryoprecipitate at a later stage this morning, Professor. But did you agree with, at the time, the opening sentence of that final paragraph, the fact that haemophiliacs are at risk for AIDS is becoming clear?
Yes, I think that's fair.
Now, we then, in January 1983, have 3 meetings which you attended. The first is a meeting of the Hepatitis Working Party on the 19th of January 1983. That's HCDO 40...
Just
Yes.
Before we move on from that document, did you want me to comment on it further?
I have no particular further question at this stage, but you're welcome to comment on it, Professor, if you wish.
Is it possible to go back to it?
Do you want the first page or the second page, Professor?
The second page. It's merely.
Do you want us to zoom in on the last paragraph again?
The last paragraph, yes, that would be helpful. The question has been raised as to, in a sense, why more wasn't done to think about moving back to cryoprecipitate, as suggested by Jane Deforge. And I think the answer for me is that I'm not sure that Jane Deforge really understood about haemophilia. I had never come across this individual before, that I've been, as you know, interested in haemophilia for quite a long time. She is, in fact, as far as I can gather, a staff writer for the New England Journal of Medicine. So I think what her suggestion is, I can see why she's made it. The papers she refers to later on in the journal by Lederman and Mintonev are correct, but the number of patients who showed normal T helper suppressor ratios in the cryoprecipitate group was very small indeed compared to the constant numbers of patients in the concentrate group, and to suggest on the basis of that it might be prudent to move towards cryoprecipitates seemed a little premature. That was my take on this, and why I think it didn't gain much traction. Had it been written by a well-known name in haemophilia, an eminent haemophilia physician, people might have, and it said the same text, then maybe it would have carried more traction.
Thank you, Professor. I will come back further to the issue of cryoprecipitate in a little while.
Thank you.
Just continuing with the chronology through January of 1983, Seamus, could we have HCDO 40558, please? So you'll see here, Professor, that this is the meeting of the Hepatitis Working Party, 19th of January 1983, at which you are present, along with Professor Bloom by invitation, I think as he wasn't normally a member of the Hepatitis Working Party, and the usual members. If we go to, I think it's the second page, Seamus. Sorry, if we keep going down the page. Next page. Sorry. Yes, so we can see the bottom half of the page under the heading Acquired Immune Deficiency Syndrome. We can see that on the 19th of January, Dr. Krask is updating members of the Working Party. He refers to having written to Dr. Lawrence at the CDC in Atlanta. He provides details of there now being 10 cases of AIDS in haemophilia A patients with none of the predisposing causes such as heroin addiction, homosexuality, treatment with immunosuppressive drugs. All except one patient were patients with severe coagulation defects on regular factor VIII therapy. He explains that the youngest is 7, that 5 had since died, and says it seemed possible that factor VIII or other blood products administered to these patients might be implicated. He goes on to explain that the CDC AIDS task force was working on the hypothesis that an infective agent was involved, possibly a virus specific for human T cells in the same way that EB virus was specific for human B lymphocytes. And then he goes on to provide an update about the 3 cases associated with whole blood or platelet transfusions, provides details of those, and then of the 3rd case, and this is the last 5 lines or so of the page, the 20-month-old boy from California who'd been transfused with blood platelets at birth, 14 months later developed an AIDS-like syndrome. One of the donors of a unit of platelets was a young homosexual who subsequently developed classical AIDS and died in August 82. And then incubation periods of that, if we go to the top of the next page, please. Cases was between 6 months and 2 years. So pausing there, Professor Ludlam, it would seem from this apparent that by the 19th of January at least, you are aware, because Dr. Krask is specifically updating you and your colleagues on the Hepatitis Working Party and Professor Bloom about those platelet transfusion cases, and in particular the Californian baby case.
Yes, I was, as you say, at the meeting, and I don't remember that particular case being discussed, but the case was eventually published in March or April 1983, and the title of the paper was Possible Transmission of an AIDS virus. It was one possible explanation for immune deficiency arising in this infant. I'm not a pediatrician, but I do know that there are a range of congenital immune deficiencies that can arise in small children, which makes them very susceptible to opportunistic infections, and they would present, I think, in a similar way to a patient who'd been infected with an AIDS virus. So it was circumstantial evidence. It didn't in any way begin to fulfill postulates for demonstrating that an agent causes a disease.
Is it fair to say, looking at this account, there's no suggestion from Dr. Krask of there being any other suggested cause? These cases are being drawn to the attention of the Hepatitis Working Party precisely because it supports the concerns and the most likely theory of there being an infectious agent and an association between blood and blood products and transmission of AIDS.
Yes, I would agree with that.
And then we can see, if we look further down the page, the long paragraph beginning, the Americans were keen. There's a discussion about reporting. There's reference to the New England Journal of Medicine, or to two papers in the New England Journal of Medicine. Everything that is set out in this Working Party paper, can we agree, is material that you would have known on or before the 19th of January 1983?
Yes, I think that's fair.
We then can see that you attended a meeting to...
just before we move on, could we go back to the document? And I'm sorry, I need to see a bit further down the document that's on my screen. Yes, you'd bring it up. I want to talk about just draw your attention to the last paragraph. It was also reported that there's been an outbreak of mycobacterium tuberculosis infection. I'm sorry, it seems to...
It's still there. In young, severely affected haemophiliacs.
Sorry, yeah. In young, severely affected haemophiliacs at the Bovarian Children's Hospital. Thank you. Skin lesions appeared to be the main lesions involved. In view of the altered response to other tests of CMI reported in haemophiliacs, it was important to determine whether haemophilia A patients on freeze-dried concentrates might be more susceptible to tuberculosis than healthy children not treated regularly with blood products. I may come back to that later, but I'm interested that at that stage we were noting this. A very astute observation by Professor Hill in Birmingham.
21st of January, there's a meeting in Scotland you attended. Seamus, it's PRSE 301736. And we can see this is a meeting of the directors of the SNBTS and haemophilia directors, 21st of January 1983. Again, you were present. If we go on, please, to page 7. And we zoom in on paragraph 6, please, Seamus. Under the heading AIDS, 6A. It said this: Dr. Cash drew members' attention to recent articles in the United States and also in the Observer and the Lancet about this problem. MMWR extract, CDC Atlanta, had been circulated with his paper. Dr. Ludlam informed members that in the UK a letter and questionnaire had been sent out to haemophilia directors. Now, we don't, I think, have, at least not currently, Dr. Cash's paper itself that appears to be referred to here. But is it reasonable to assume that the MMWR extract is likely to be the December MMWR?
I'm sorry, what was the date of the meeting?
21st of January 1983.
I'm sorry, I'm not at all certain that it would be the December. It would have come by post at Christmas, over Christmas time and the holiday period. I'm sorry, I can't.
Don't worry.
It might be the July version. the first three cases.
Well, we can no doubt ask others who were present at the meeting. It may be a feature of the compressed nature of minutes, but there doesn't seem to have been much of a discussion about the implications, either for Haemophilia Centre directors or for SNBTS, of the developing knowledge in relation to AIDS at this meeting. Do you recall anything about it?
I'm sorry, I don't remember the meeting. I'm sure there was a short discussion, and I think I would have said that this was being thought about by the Hepatitis Working Party and UK CDO. I'm sorry, I can't speculate more than that.
We then come on to a meeting on the 24th of January 1983. Seamus, that's PRSE 402647. PRSC 402647. Should be in the general bundle that's common to all the witnesses, Seamus. So it's not a specific to this witness.
Is it 4 zeros or 3 zeros?
Ah, you are absolutely right, sir, and the fault is entirely mine. I've put in an extra zero, Seamus. My apologies. PRSE 0002647. Thank you. So we can see, Professor Ludlam, these are notes, we think these are notes from Dr. Bolton of a meeting with Immuno at London Airport on the 24th of January 1983. If we just go, first of all, to page 4, and we look at the list on the bottom half of the page, please, Seamus. We can see that there were a number of attendees, including yourself. Yours is the fifth name listed. So there are various reference centre directors there, but also other Haemophilia Centre directors. We can see, for example, Dr. Colvin, Professor Hardesty, Dr. Arenstam, Dr. Hill, as well as, for example, Professor Zuckerman, whose interest would no doubt have been in hepatitis. Other documents tell us that this was a meeting that probably took place at the Excelsior Hotel at Heathrow Airport in London on the 24th of January 1983. Do you have any recollection of that meeting and the circumstances in which it was called?
I don't. I have a recollection that the meeting took place, and I mentioned that, I think, in my long statement to the inquiry. Beyond that, I have little recollection of the contents of the meeting.
I appreciate it was a long time ago, but it would seem at first blush to have been quite an unusual meeting. It's out of the ordinary. It's not part of the usual chain of UK HCDO meetings, for example. And it's a meeting specifically attended by this large number of interested clinicians with Immuno. Was that not something unusual, or was that a regular occurrence?
In my experience, this was not a regular occurrence. This was a one-off meeting. I don't think I've been invited to a meeting like this before. May not be entirely accurate, but certainly these sort of meetings weren't regular meetings in any sense. I think the purpose of the meeting, having seen this record from Frank Bolton, was primarily to tell the audience, this list of people, the work that Immuno were doing to try and improve the viral safety of their concentrate, factor VIII concentrate. And I think this was really a way of advertising the research they were doing, hoping to get the interest, I imagine, of the attendees.
Yes, I mean, you're absolutely right that the first part of the meeting seems to have been occupied by discussion of what's referred to as hepatitis-reduced factor VIII and factor IX concentrates. But if we go to the third page, please, Shomik, so that's the page before this. We can see under the heading Acquired Immunodeficiency Syndrome, so it's the bottom half of the page, please, that there's a further update from Dr. Krask. I won't go through the detail of all of it because we've seen similar updates from him already from the Hepatitis Working Party document. But if we look at under the heading AIDS, the fourth paragraph talks about up to 10th of December 82, some 800 people have been reported as suffering from AIDS, 45% mortality. There's then reference to, again, the figures of 10 haemophiliacs in the US, 5 have died, youngest 7. All cases have had prolonged treatment with factor VIII. There's no specific implication of one particular product or batch. Then there's reference to the 3 platelet transfusion cases, including the young child. If we go on to the top of the next page, we can see reference to the incubation period, refers to 1 or 2 cases having been reported from the Communicable Diseases Centre so far in the UK. There's then a discussion of protocols from the United States, including in relation to donor screening. And it's said that those are being considered by the Hepatitis Working Party. There's then reference to the editorial in the New England Journal of Medicine on the 13th of January, and the issue in relation to cryoprecipitate. And then we see final comments on the possible nature of the transmissible agents indicated that there may not be just one agent, but a mixture, i.e. a barrage of viruses, including hepatitis B, non-A, non-B, CMV, and many others, possibly transmitted from asymptomatic healthy blood donors. Professor Ludlam, would you agree that whilst obviously there is still much that is not known, maybe a considerable number of uncertainties, there is no suggestion here that the cause in either haemophiliac patients or transfused patients is anything other than the receipt of blood or blood products?
I agree that is as set out by Dr. Krask, but of course Dr. Krask is a virologist and would see things from a virological perspective.
Yes. There are many others attending, however, who include amongst their number many haemophilia specialists. We don't see recorded in this note, and of course it's just one note and you have no independent recollection of the meeting, any alternative theories being put forward by haemophilia directors.
I would need to see the rest of the document to see how it records the discussion. So I can't see on the screen.
Well, in terms of...
Or maybe there is no discussion recorded.
There is discussion recorded at various points in the notes in relation to hepatitis-reduced factor VIII and factor IX concentrates. So the note doesn't simply record, for example, Dr. Ebel from Immuno's presentation, but records the interventions of Professor Zuckerman, and it said that there was considerable discussion. In relation to AIDS, if we go back to the previous page, Dr. Bolton's note in the first line under Acquired Immunodeficiency Syndrome report says this was discussed in the after-lunch period. We then refers to Dr. Krask's summary. If we go over then to the fourth page, the last paragraph before the list says final comments. That might suggest that those are comments from those attending the meeting, but certainly Dr. Bolton's note read as a whole incorporates comments from attendees in relation to hepatitis. Does that assist at all with your memory?
Not particularly, because I don't remember the meeting. These are notes. I think the document is headed notes from the meeting, not a minute or a record of the meeting. In other words, there may have been, and it is clear there was discussion that isn't recorded here. I'm not prepared to speculate as to what was discussed beyond what's stated here.
Do you have any recollection yourself of any discussions either at the Hepatitis Working Party meeting that you attended on the 19th of January or any other meetings around this time at which haemophilia directors were discussing alternative theories other than a causal link with factor concentrates?
Yes, in the meeting of the 19th of January, the Hepatitis Working Party, there is some discussion about looking at the possibility of assessing immune function and having noted that it was abnormal in asymptomatic people with haemophilia in the US, as reported in the 11th of January New England Journal. There was discussion about what that might mean, and the minute records suggestion that it would be interesting to look and see what the results of lymphocyte subset tests were in patients who had been treated purely with NHS factor VIII concentrate, because it was rather less likely that those recipients would have been infected, if there was an AIDS virus, by an AIDS virus that was circulating in the United States at that time.
Other than what you recall or what you said you've drawn out of the minutes of the Hepatitis Working Party, can you recall any other discussions that took place amongst haemophilia centre directors in early 1983 about the causes of or potential causes of AIDS in haemophiliacs?
I think there was much puzzlement, and although 10 cases had been reported in the United States, that's out of a population of 320, 330 million, 5 times that of the UK. So it'd be equivalent to 2 patients in the UK. So in overall terms, it was a small number, and we were very puzzled by the cases. There appeared to be a few at that stage, and the cause was much thought about.
Just a moment on the maths there. The 10 cases are cases of haemophiliacs, aren't they?
And that's correct. Yes.
So the relevant population is not the total population of the states, is it? It must be the population in the states of haemophiliacs.
Oh yes, I was. But the number of haemophiliacs is proportional to the total population.
Yes.
And in the UK, it's roughly 5,000, and the United States, it's probably about 25,000.
Yes.
People with haemophilia. So that's I'm suggesting that the US population of people with haemophilia was probably about 25,000, and it's 5 times the British number, and therefore on a per head basis of haemophiliacs, it would be a 5th if it was the UK.
Yes, thus far. Yes.
Yes. Oh yes. Oh yes. Yes.
If we can then look at one further publication from January, Professor, it's RLIT 40201. We can see that this is an article in the Lancet, January the 29th of 1983. So an article you would be likely to have read, is that fair?
That's true, yes.
Acquired immunodeficiency-like syndrome in 2 haemophiliacs. And we can see from the summary, there's an evaluation of the immunological status of 2 multiply transfused patients. And then if we look at the last sentence of the summary, transmission of an infectious agent in blood products seems likely. So again, Professor, whilst accepting, of course, there are uncertainties and lack of proof, the likeliest cause being advanced here and in all of the documents we've looked at is transmission of an infectious agent, is it not, as the cause of AIDS in haemophiliacs?
I would agree that in the discussions, an infective etiology was the most likely cause, yes.
So would you accept that by the end of January of 1983, you as a haemophilia centre director would have appreciated that the probable route of transmission for haemophiliacs was blood products, although you might not yet understand what the etiology is and there may be a range of different theories. In all likelihood, the most probable cause was transmission through blood products. Is that fair?
I think it's fair to say that people with haemophilia appear to be acquiring AIDS as a result of their treatment with clotting factor concentrates.
And you would also have known by the end of January 1983, again, whilst recognising there was still much to learn about AIDS, that it had a very high mortality rate.
Once an individual developed an AIDS-defining illness, which in the early days of AIDS was predominantly Kaposi's sarcoma in homosexual men and pneumocystis carinii pneumonia in others. You only get, or you tend only to get, pneumocystis in people who are very severely immunocompromised. In other words, they've been, as we now know, infected probably for quite a long time, and by the time they're diagnosed by this clinical means of getting PCP, then their outlook was not good, and that's how it came to be. Once you cross the threshold of AIDS, particularly being defined by PCP, then your outlook was poor, and the figure you quote is reasonable.
And you've touched on what may have been the third important feature at the time, that it was at least beginning to be understood, or if not already clear, that there could be a significant lapse of time before the onset of symptoms and a further significant lapse of time before diagnosis.
That's correct.
So the fact that currently the numbers of cases might be said to be comparatively low as hard figures, that wouldn't necessarily be a reliable guide as to how many might be infected.
That is true.
Can I ask you to look at your statement, please? Shomik, it's WITN 3428001. And could we go to page 80, please, Shomik? Actually, could we put page 80 and 81 side by side? So I just want to ask you a little more about what you've said in some parts of your statement here. You've said in paragraph 209A, which asked what actions you took to reduce the risk to your patients of being infected with HIV. You've said at 209A, assume that AIDS might be caused by a transmissible agent. If we look across the page to paragraph 211, in answer to the question, did you continue to use blood products after becoming aware of the possible risks of infection and why? The first reason you put forward is you continued to use blood products after it became apparent that AIDS in 1982 might be caused by a transmissible virus. Because initially there was no definitive evidence that AIDS could be caused by a transmissible agent apart from the reports of AIDS being reported in a few individuals with haemophilia. Which approach shaped your approach to treatment? An assumption that AIDS might be caused by a transmissible agent, as you've described in 209A, or the view that there was no definitive evidence and therefore no need to take any steps at that time?
No, I would take the view that there's a possibility, as set out in 209A, and therefore it was reasonable and appropriate to review treatment on that basis.
So what, if any, steps or changes were taken at Edinburgh in 1983 in response to the understanding that there was a risk to haemophiliacs from AIDS?
At that time, as you know, we were treating virtually all our patients with either cryoprecipitate or NHS, Scottish produced, PFC produced factor VIII concentrate. And we were taking measures to reduce the risk, or to keep as low as possible the risk of hepatitis being contracted in patients, particularly those who weren't infused very often, or if possible in small children. I was aware and made inquiries that there were no cases of AIDS had been reported in the Scottish population. And so I made the assumption that the likelihood of there being a transmissible agent was low in Scotland. I contacted the infectious diseases unit at Ruckhill that collected the data, rather like Dr. Galbraith's centre in Colindale at the PHLS, and they had no knowledge of cases. And I made a number of other inquiries, and I'd not heard of any cases. So on that basis, I thought that the risk was small, but not negligent, and not zero.
Does it follow from the answer you've just given that there was no significant change of approach to treatment in 1983 and 1984 on your part, because you assumed, for the reasons you've given, that the concentrates you were using were safe?
Reasonably safe, I think.
Yes.
Yes, relatively safe. I think that's fair. Yes.
Did you consider, in the course of 1983 or 1984, a much greater use of or reversion to cryoprecipitate?
I'm sure we must have done. I don't recall discussion, but there would have been some discussion, I'm sure, with the blood transfusion service, as just if we were to go back, as we were discussing yesterday, they had turned their whole system over to producing as much factor VIII as possible for my apparently insatiable demand. And I'm sure we had some discussions, and I know from documents that have been produced subsequently that it was a view that it would technically have been actually very difficult to have gone back, and it had all sorts of other implications I'm happy to talk about if you would like, but there wasn't a decision made. I'm sure it was discussed, but we felt it reasonable to go on with using cryoprecipitate in decreasing amounts and using local concentrate for treating the patients.
We'll look at one record of a discussion along those lines, if we may. PRSE 301556. You'll see, Professor, these are the minutes of a meeting of SNBTS and Haemophilia directors, 2nd of February 1984. Again, you are present along with other director colleagues and SNBTS representatives. If we go on to the second page, approximately halfway down, there's little Roman 2. Members discussed the suggestion that the production of cryoprecipitate could now be reduced. Dr. Ludlam said that cryoprecipitate was preferred in the treatment of children at present because of the new danger of AIDS. Dr. Han concurred. A policy seemed to be emerging, however, to use less cryo for haemophilia A patients. It was agreed that a certain minimal amount of cryo was required, and Dr. Cash pointed out that TDs could produce it in emergencies. So it would appear that by February of 1984, leaving aside the position of children, which you and Dr. Han have there identified as recorded in these minutes, the approach appears to be, notwithstanding the danger of AIDS, using less cryoprecipitate for haemophilia A patients rather than more, which might be thought to be a somewhat surprising response to the new danger of AIDS. Are you able to assist with why that was the approach that was taken?
Well, I think the way we were trying to manage at that time was in keeping with the guidance issued by UKHCDO in June, is it June the 23rd, 1983, which suggested that NHS concentrate would be an acceptable form of therapy for patients with haemophilia.
Would you agree that the natural understanding of what's being said here, not least by you, is that cryoprecipitate was seen as a safer treatment than NHS concentrates? That's the very reason that you're preferring it and Dr. Han is preferring it for children.
Yes, I obviously not scrutinised these minutes carefully, and nor does it probably record, or certainly doesn't record all that was said. but it doesn't say also using cryoprecipitate for children because of the hepatitis risk.
No, it specifically singles out the danger of AIDS as a reason for preferring cryoprecipitate for treating children. Why would those same considerations not also apply to adults with haemophilia?
Because adults require larger doses of treatment, and therefore there's much greater donor exposure. That's one of the reasons why adults treated with cryoprecipitate are at greater risk than children.
Surely adults, for that very reason, adults treated with concentrates who are being exposed to thousands and thousands and thousands of donations and are heavily treated are at greater risk from concentrates than from cryoprecipitate.
Well, they might be. The infective risks of cryoprecipitate are not negligible, even for viruses that are screened. I can give you an example. I was doing a ward round one day and someone came running up from the local blood bank to ask us to take down a bag of cryoprecipitate that was being given to a patient because he had just discovered that it was a hepatitis B antigen positive donation had gone into it by mistake. Unfortunately, by the time we got to the patient's bed, all the cryoprecipitate had run through. So there was a patient exposed to a large dose of hepatitis B antigen as a result of an administrative error, presumably, in the blood transfusion service. So that if you get an infection from a unit of cryo that's infected, then you get potentially a big dose of it. I was quite concerned that this patient might develop immune complex disease because he had a very high level of antibody to hepatitis B. But let me move to the risk of concentrate and pool size. There is the assumption made that if one donation in a pool is infected with a virus, that the whole pool is contaminated, which is true, and that will automatically result in infection in the recipients. During the manufacture of a clotting factor concentrate, particularly factor VIII, there are a number of steps. During those steps, the virus can either be inactivated or destroyed, or it can be neutralized by antibodies present in other donors. It is actually established that in the preparation of clotting factor concentrate, so factor VIII concentrate, that there is a destruction, a tenfold destruction of HIV. This is all known, obviously, retrospectively. So there is some destruction of virus. It is also diluted. in the concentrates, in the pool that's contributed of the donors. There is, when patients are exposed to a virus, they need to be exposed to what's called an infectious dose. That is the dose that infects 50% of the recipients, is my recollection from many years ago of this. So what I'm trying to say, I'm sorry I'm a bit slow, that one donation to a large pool that is then processed to produce clot-infected concentrate doesn't mean that every bottle that's produced of that concentrate will infect a recipient. So it's a slightly long answer to, and I'm not sure I've fully addressed your question, but I've tried to show that it's not quite as simple as just assuming that cryoprecipitate will be safer than concentrate.
Can I take you back to February 1984, which is the date of this meeting? And it's obviously a not insignificant date, given the dates of seroconversion of your patients who were subsequently infected with HIV from concentrates, not from cryoprecipitate. In February 1984, what was your understanding of the relative risks of cryoprecipitate and factor concentrates in relation to the risks of transmission of AIDS?
Are you asking about the risks as I perceive them in Scotland or in England or in the United States?
In the United Kingdom and then specifically in Scotland.
In England, by 1983, there were individuals who had AIDS in the general population. So there was a risk that some of those potentially could present as blood donors. And therefore there was a risk, I can't put the figure on it, but there was a risk that NHS concentrates and cryo and other blood products could be infected. In Scotland, as I mentioned a moment ago, I wasn't aware, nor were the authorities I consulted, and no one drew to my attention any individuals, any known cases of people developing AIDS who could have been blood donors.
So in February 1984, did you think that NHS concentrates that you were using were safer than cryoprecipitate or less safe than cryoprecipitate?
Moment, I find that a difficult question to answer because I thought it likely that the risk of infection, if you like, in the donor population was low. Cryoprecipitate for other reasons, if you like, the hepatitis B is an example of a virus that is very infectious if I can put it that way, you need only a very small dose. The number of virus particles to infect an individual is very low. In other words, it's highly infectious, and that's why it spreads so well.
Okay. Can I just, could we go back to the document, please, Shomek? It's PRSC 301556. Second page. And if we just zoom in on that same paragraph, subparagraph 2, members discuss the suggestion. Just slightly further down the page, thank you. I'm going to press you on this, Professor Ludlam, because it would seem that the reason you are saying here that cryoprecipitate should be used for children, and Dr. Han is agreeing, and obviously I can ask Dr. Han this next week, is because cryoprecipitate is seen as safer in relation to AIDS. Do you accept that's what you're saying?
That's what's recorded, yes.
Are you suggesting that wasn't your view in February 1984?
I'm sorry. I just feel a bit tired. I'm not trying to be difficult. Because I don't recall the discussion. It's possible that I said that, and it could be argued that the risk would be smaller with the use of cryoprecipitate.
Would you agree that there doesn't appear to be recorded here, maybe you will tell me it's recorded elsewhere, discussions about the any practical obstacles to using cryoprecipitate more?
Yes, there were difficulties in the blood transfusion service because, as I mentioned a few minutes ago, although I couldn't recall the discussions, there are documents put together by, I think, Professor Cash, which I think I have sent to the inquiry has, what's perhaps in my statement, indicating that it would be very difficult for the blood transfusion service actually to increase its cryoproduction at a time when they were on the verge of being able to introduce a virucidal process into the manufacture of concentrate.
Well, we can no doubt ask that question of Dr. Cash or other SNBTS witnesses. Did you, at this time, or indeed any other time in 83, 84, discuss with patients and the risks of AIDS and offer them specifically the choice of reverting to cryoprecipitate?
I have to say at this distance, I don't remember discussion, patients asking me about the risk of AIDS. You've received a statement, I think you requested a statement from Dr. Carr, who worked with me, and I understand you've received that. And he states he has clear memory of patients asking about the issue of AIDS. I was thinking about it in relation to something we may come on to later. I was a bit surprised that it hadn't been raised. But that's, I'm sorry, that's the best my memory is. There may be some more in the transcripts or my evidence, Penrose, well, there will be more because my memory was considerably better then than it is now.
So I note the time. We can
Yes,
take
well,
a break now.
we'll take a break. I'm sure you could probably do with one. You said you were getting a bit tired a few minutes ago. There is just one thing which I'd like to ask you before we stop, since we've been discussing it. If we can go back, please, to your witness statement, 3428001, and go, please, to page 81. Thank you. And it's paragraph 211, little a. You were asked by counsel about the contrast between that and what you said at 209A, but I want to focus here just for a moment on the language that is used. Now, it may simply be casual use of language, although you don't strike me as a particularly casual user of language. What you say is there's no definitive evidence that AIDS not was caused, which I would understand, but could be caused. So no definitive evidence that it was a risk of being caused by a transmissible agent. Is how it actually reads as a matter of literal text. Did you mean that? Or did you mean no definitive evidence that it was caused?
Yes, I'm sorry. It's your wording is more accurate.
Because there couldn't be any doubt. There's plenty of evidence, whether you define it as definitive or not, doesn't much matter. Plenty of evidence there was a risk that it was caused, could be caused, wasn't there?
Yes.
Right. That was all that I asked. Thank you very much. So we'll take a break now until we'll make it 10 to 12, shall we?
Thank you.
10 to 12.
Thank you. Thank you.